All right, I think we'll start now. Welcome to Vijaya Diagnostic Educational Webinar Series. This webinar we conduct with a clinico-radiologic aspects so that there is a good interaction between the radiologist and the clinician with aim to eventually give the best to our patients. So today we have a very important topic, evaluation of myocardial viability in coronary artery disease, cardiac MR versus nuclear cardiology. So coronary artery disease is the major killer throughout the world, we all know it. And when the patient develops coronary artery disease, I'm sure the most important question which cardiologists would like to know is how much of myocardium is necrosed or infarcted and how much is still available, maybe ischemic, but still viable and which can be salvaged. So to discuss this very important topic, we have three very young, dynamic, dashing individuals. First is cardiologist Dr. Pankaj Jariwala. He is a senior consultant interventional cardiologist in Yashoda Hospital. And he is basically an MD pediatrician. And then he did DNB cardiology. And eventually he had interventional cardiology fellowships in France, Paris. And his special interest and expertise is in the interventions. Percutaneous transluminal coronary angioplasty. He has performed more than 5,000. Percutaneous aneurysm repairs and the stent graft for aortic aneurysms, a lot. And being a pediatrician, I am not surprised that he has got a lot of interest in the congenital heart diseases also. And I can see that his research and publications are running into several pages. I don't think we'll have time for any of those things. Among the awards,
not required.
Among right. Among the awards, there is one thing I would like to mention is he got the Best Cardiologist Award of Hyderabad in 2015. Welcome, Dr. Pankaj.
Thank you, sir.
And then I have a radiology colleague, Dr. Deepak. He is consultant radiologist working with Vijaya Diagnostic. He has 11 years of experience and he is one of the most decorated radiologists. He is MD, DMRD, DNB, Diploma of Radiology from Europe and FRCR recently. And he is passionate about coronary CT and the cardiac MRI. And he will be talking about cardiac MR and what is its role in assessing the viable myocardium. And then we have another colleague of mine, Dr. Mansoor Mohiuddin. He has done his DNB nuclear medicine from Apollo. And before joining Vijaya, he has worked in Care Hospital, Continental, Nizam's Institute. And his CV is also very impressive, but I will cut it short. He got Professor Arkot Gajraj Best Paper Award. And he also got the Austrian Vienna Travel Fellowship. So welcome to all of you. And now I will first start with Dr. Pankaj. Pankaj, please tell us, when patient comes to you and you suspect coronary artery disease, how do you clinically approach these patients and when do you request for myocardial viability studies?
Yeah, sir, actually, as far as the nuclear study or whatever may be the MRI studies, there are two aspects for us. One is there are many times when we do angiography, we find that there are some borderline coronary artery disease there. So in those cases, we want a stressed myocardial perfusion imaging. So we are totally dependent on the stressed myocardial perfusion imaging to know whether it is any irreversible ischemia is there or not. And if it is there, where it is a small or large, equally more than 10 to 15% of the myocardium. So if there is a large area in chronic stable angina, there is a lot of controversial aspect whether medical management should be done or intervention should be done. And there are various trials has been done, and they said that angioplasty doesn't have much role in patients of chronic stable angina. Of course, in acute coronary syndrome, when patient is having acute myocardial infarction, there is a already proven role of angioplasty in group of patients. But those patients who come to us like only positive treadmill test, who is not having any symptoms, and we do angiography and patient denies any symptoms. So before putting stent, I want to make a doubly sure that patient is having a large territory of myocardial infarction is involved. So that is one aspect of doing a nuclear stress test in this group of patient. And of course, as an intervention cardiologist, we do a lot of FFR also. That is fractional flow reserve. We pass a wire, and for the significance of the lesion, that test also is available. And we do optical coherence tomography or intravascular ultrasound also by imaging. And there are studies where there is a good correlation between the stress myocardial perfusion imaging and FFR. So many of the times I have some of them very close patients of mine where the FFR has come positive. I have not stented them. I have sent them for even stress perfusion MPI, and I found that it correlates very well. So that is one aspect of the nuclear stress test for me. Another stress test where I use as a clinician very much is somebody comes to me with acute myocardial infarction and interval myocardial infarction, and the LAD is a culprit vessel which is 100% occluded, and I do angioplasty for that vessel. But when I do angiogram, I find that there are other non-culprit vessel stenosis is there, like circumflex or right coronary artery, and patients are totally asymptomatic. Once they have completed 3 months, 4 months, 6 months angioplasty, and looking at angiogram, we say that now we have to go for angioplasty again. But patient says, why should I go? I am totally asymptomatic. I don't need to do. So that time I advise for stress myocardial perfusion imaging to know what is happening to the LAD territory which I have done angioplasty, how much is the viable territory, and what is the status of the inducible ischemia is there or not in other territories. If the other territory shows, there was one case which patient came with inferior wall myocardial infarction, and I did angioplasty to right coronary artery, and his LAD was having 90% stenosis. And after doing angioplasty, after 2 months, patient had profuse bleeding, GI bleeding, and because of antiplatelets actually. So now we were planning to go for angioplasty to the LAD territory, but now having already one stent and I want to put another stent, already he has bled very profusely. I ordered stress myocardial perfusion imaging. And to my surprise, I found that in LAD territory, despite there is a 90% blockage, stress myocardial perfusion imaging showed there is no indicible ischemia. On the contrary, there is 90% stenosis in LAD. Now I said patient that you don't need anything now because there is no ischemia in the LAD territory, and already you have bled so much. He was having so profuse bleeding. Even our gastroenterology colleagues were not able to point out from where it is bleeding. We did all possible tests, including capsule endoscopy and even the nuclear tests like RBC gated test to know where from he is bleeding, but we could not find out from where he was bleeding. So in such a patient, such a difficult patient who has already had so much of bleeding, I cannot do without the stress test to put another stent in another artery. So the stress myocardial imaging has helped me a lot, and now that patient is on active medical treatment with only single antiplatelet therapy, and is doing very well. So that is the role it plays in our day-to-day activity. And another third area is somebody who has LV dysfunction, and I find that patient is having multivessel disease, whether it is a moderate LV dysfunction or severe LV dysfunction. And before I go for any angioplasty or bypass surgery, I want to know the viability of the myocardium. So there we don't do a stress test. I'm not interested in the patient is whether having inducible ischemia or not, because in severe LV dysfunction, doing the stress is little difficult because already patient's LV ejection fraction is hardly 25-30%. So if you subject them for stress, we will have some adverse effects and there will be multivessel disease. So I want to only know that whether patient is having any viable territory or not. That is the only thing I want, because if there are CTO, chronic total occlusion of any vessel like right coronary artery or LAD. I want to know the viability of that area, whether I should revascularize that or not. Because somebody is having triple vessel disease, it is a case of bypass surgery. So, but if one area is totally non-viable, and I can do angioplasty to that patient rather than subjecting him to for bypass surgery, which is going to be high risk surgery in this group of patient when somebody is having severe LV dysfunction and all those things. So if it is a non-viable territory, LAD is non-viable, then I can straight away do angioplasty to other two vessels. Recently, I did viability study from your EDiR diagnostic only. They did viability study. He is my clinic patient, and right coronary artery was totally occluded vessel, and it is basically they showed partial viability. 1 year back, I had done his angioplasty. That time it was a non-viable territory. RCA, I did circumflex and ramus angioplasty, but now Dr. Anuj Jain gave me the report saying that there is a partial good viability is there, and now we are thinking of bringing him back and doing again RC angioplasty because it has shown good viability now. So it is like a stage PTCA for that patient. So,
Right.
so this is all what I think, and of course, nuclear imaging also we do. But problem is we are not getting good reports in MRI. Actually, in Hyderabad, we are lacking good image of MRI actually. So I am little questionable for me to send any patient for MRI. Of course, I have not tried with your center, but stress MRI nobody is doing. Dobutamine stress MRI or something like that. So we don't do any stress MRI. I have not seen anybody doing. Only viability, late enhancement of gadolinium, and for making diagnosis, I have been doing MRI. But we rely more on nuclear stress test because experience of our colleagues, radiology colleagues, also is very good with nuclear imaging.
Right. So thanks a lot, Dr. Pankaj. You gave a very good input regarding the clinical approach and what you expect and all that thing. And I think I would request Dr. Deepak to start with his presentation. And let us see whether he is able to change the mindset of Dr. Pankaj, and whether he would start sending more of MRI than nuclear medicine. So Deepak, it's your turn now, please.
Yes, sir. Am I audible, please?
Yes.
Yeah, please. You're audible.
Thank you, sir. Thank you for the kind introduction, and thank you to Dr. Pankaj for the wonderful clinical questions and clinical information what we as radiologists really require. That was a good insight. Thank you, sir, for that. And today's talk, I'm going to focus on the MRI part of myocardial viability assessment in coronary artery disease. I'm Dr. Deepak, and we'll straight away go into the talk. I have no relevant disclosures, and there has been fair usage of copyrighted material, and I'm going to discuss this topic in several subheadings. The first being, we're going to see what exactly is coronary artery disease, a brief overview. This is for the benefit of the audience, and what happens in cardiac MRI. And next, we're going to see few case examples and what are the advantages of MRI, and we are going to touch upon the recent advances in cardiac MRI. Coming to the first aspect of the talk, which is coronary artery disease, there are three main arteries supplying the heart, which is LAD, RCA, and LCX. So atherosclerosis disease of these arteries is called as coronary artery disease. And it is important to note that this starts as early as second decade of life, and the disease process can be multifactorial. It can be due to many risk factors, but more commonly the diabetes, smoking, and a positive family history are the most important ones what we see in day-to-day practice. And this is a schematic presentation of a picture of the disease process as such, what happens in atherosclerosis, what happens in the vessels, right from a normal vessel to having plaques, and then having vulnerable plaques, and then rupture, myocardial infarction, and then followed by stable plaques if the patient survives. This is what actually happens in atherosclerosis. It is like diseased, aging process of the coronary artery vessels. And due to this, pathologically what we see is initially there'll be intimal thickening, there'll be fibroathromas, and the most important stage is the thin cap fibroathroma, which ruptures and which can cause ulceration and myocardial infarction. If the patient survives, this type of plaque becomes a nodular calcified plaque, which is a stable plaque. Because of this disease process in the arteries, the end organ damage, that is the myocardium, that is the heart muscle, gets damaged. There is, depending on the temporality, the point of the time sequence, initially there will be a lot of inflammation and acute myocardial injury. That will be followed by, if the patient survives, it will be followed by tissue damage, which will be predominantly due to scar tissue or fibrosis in the non-viable myocardium. Pathologically, it can be either reparative or a replacement fibrosis or a diffuse myocardial fibrosis. And when we do MRI, we should, the main idea is to detect non-viable myocardium and give an idea of what is the burden of myocardial scar tissue in that particular patient. We know that there are different types of normal and abnormal myocardium. It can be normal, it can be stunned, and it can be hibernating, and it can be non-viable. So the last one, the non-viable myocardium, is what we are interested in looking at, and also the hibernating myocardium when we do cardiac MRI. Now, I'm going to touch upon what exactly the procedure of cardiac MRI. This is for the benefit of the audience. The entire process takes about 30 to 45 minutes, and patients are generally put into the MRI machine. MRI machine is basically nothing but a large magnet. Every human body consists of multiple cells which do contain lot of hydrogen nuclei, which are protons. They also act as minute magnets. So when the body is put into the MRI machine, these align themselves into the magnetic field, and we do MRI, and we get some signals from this, and then we get the images using robust computer programming, and then we get different set of images. We acquire different set of images called as black blood sequences, white blood sequences, outlet imaging, and then there is something called as stress imaging, which is, like Dr. Pankaj rightly pointed out, adenosine and dobutamine stress imaging. And then the most important cornerstone or a pillar of cardiac MRI is a gadolinium imaging. That is, we give intravenous contrast agent, gadolinium, and then we do early and late gadolinium imaging in cardiac MRI. Following this, we do valvular flow function analysis. When we also look at, as radiologists, we're also expected to look at the coronary artery origins and proximal segment evaluation, although CT coronary angiogram is much more sensitive and specific for evaluation of the arteries as such. And the entire, like I said, the entire study time is roughly about 30 to 45 minutes, depending on what sequences we do. Most of the time, the cardiac MRI is tailored to a particular clinical question to be answered, or a particular clinical patient. So this is an example of a black blood sequence where you can see the blood is actually black. That's why it's called as black blood sequence. These are the initial sequences what we do in cardiac MRI. Then I'm going to also show white blood sequence, also called as a Cine sequence. In this, there are images of the beating heart. This gives a very valuable information as to what the regional and global myocardial motion abnormalities are. We can do functional analysis with this kind of sequences. These are also very, very important sequences in cardiac MRI. And when the clinician sends a patient for a cardiac MRI, there are certain clinical questions which have to be answered. They're interested in knowing what is the global and regional ventricular function, which we get a very good information in MRI. And they're also interested in knowing what is the myocardial viability. Is there a viable myocardium or not? And if there is a scar tissue, what is the burden? What is the percentage of scar tissue? Will the patient benefit from revascularization therapy or not? These are the kind of questions. And of course, status of coronaries is what they're interested in knowing. That we also do CT coronary angiogram or a conventional angiogram to get that information. So these are the important clinical questions which has to be answered when a patient is undergoing cardiac MRI. Like I said, the main sequence in cardiac MRI is a late gadolinium enhancement. The principle of this imaging is that there will be late or delayed washout of contrast from fibrosis and scar tissue, which is a non-viable myocardium. So this particular principle is exploited in cardiac MRI in late gadolinium and early gadolinium enhancement sequences. So what is important is the patterns of enhancement are very specific to different pathologies. Therefore, you have a specific pattern for ischemic and non-ischemic pathologies, and they always follow this pattern. So this becomes a very important aspect to differentiate different types of pathologies in cardiac MRI after giving contrast. Uh, Generally, typically, when we say a particular part of the heart is not viable, it has to have certain parameters in cardiac MRI. And speaking in radiology terms, a thickness of less than 5.5 millimeters and presence of akinesis or severe hypokinesis and presence of late gadolinium enhancement, two patterns, which is transmural or subendocardial pertaining to arterial territory. These three important points are required to make a diagnosis of non-viable myocardium in cardiac MRI. Like I said, this is from a journal, and this shows us different types of patterns of enhancement in cardiac MRI. And like I said, the first two patterns, that is the transmural and the subendocardial patterns, are the patterns which are seen in ischemic heart disease or coronary artery disease. And the other patterns are generally seen in non-ischemic type of heart disease. So this is an important step where you can actually differentiate the pathologies in cardiac MRI. Now, I'm going to show some case examples like what we've seen. So I said there is a transmural pattern of enhancement. So in this patient, this is one of our patients where we can see a typical transmural pattern of enhancement in the apical region and anterior wall of left ventricle. So the entire wall of the myocardium enhances, and it is a sharp zone of transition between normal and abnormal myocardium. This is very typical of an ischemic pattern of transmural infarct. And this is another patient with a subendocardial infarct. This is again a typical pattern of ischemic or coronary artery disease where there is scarred myocardium. This pattern of subendocardial, that is, it is the inside aspect of the endocardium, is showing late gadolinium enhancement, and there is also thinning of the myocardium in that particular region corresponding to the particular arterial territory. Another important finding what we see sometimes is to detect the presence of microvascular obstruction. This is a very important point what we see in cardiac MRI, where in early phase of gadolinium, post-gadolinium study, that is post-contrast study, we see an area of non-enhancing myocardium within the scar tissue. This later on fills up with contrast. This is very typical of microvascular obstruction. If this is seen in a particular territory, this indicates not so good prognosis in improvement of LV function post revascularization. So therefore, this particular finding, if it is there in that particular patient, it has to be definitely mentioned and discussed with the clinician, regarding further management, because this could be a poor prognostic indicator. Now, there can be detection of LV aneurysms or any other coexisting pathologies incidentally seen when we look for late gadolinium enhancement, because the MRI gives us a wholesome view, entire view of the heart and also the surrounding structures in the chest. So this is one such patient who came for scar burden assessment and viability assessment to us. And then we also got to see a left ventricular thrombus. This is an important clinical finding which also was picked up incidentally in cardiac MRI. So you can see at the left ventricular apex that there is a dark area which is sitting in the subendocardial and cavity region. This is very typical of a left ventricular thrombus. We can also see the scarred and thinned out myocardium showing subendocardial enhancement. And another patient, this is an upcoming diagnosis where we see a lot of patients called MINOCA, that is myocardial infarction with non-obstructing coronary arteries. Patient will have chest pain, a coronary angiogram will be done, that will show nothing significant, probably not significant obstructive lesion in the coronary arteries, but patients will have features of myocardial infarction. These kind of patients can also be sent for cardiac MRI, where you can see occult changes in the myocardium. That is, this is one such patient who had chest pain, who had all the features pointing towards a myocardial infarction, but a coronary angiogram was reportedly normal. So this patient was sent to us for a cardiac MRI, and you can clearly see that there is a perfusion defect in the rest imaging, and there is subendocardial infarction in hereditary, along with a small thrombus sitting in the cavity. So this is again another important aspect of cardiac MRI, where you can actually detect unsuspecting occult pathologies, because like I said, the coronary angiogram was normal in this particular patient. So in cases of MINOCA and INOCA, uh, cardiac MRI plays a very crucial role in detecting the abnormalities in myocardium. And sometimes patient will be being evaluated for chest pain and other atypical chest pains, and we also get to see non-ischemic related pathologies incidentally. So that is also another advantage of doing an MRI. So this is one such patient after a COVID-19. He was affected twice in both the waves, but he continued to have chest pain. So this patient was sent for an MRI, and we did see a pattern of enhancement which is not typical of ischemic pattern. You could see the epicardial pattern of enhancement. This is again typical of a post-COVID viral myocarditis. And coming to stress imaging, like we've discussed earlier, adenosine MRI is very promising tool in within MRI, where you can where a slow infusion of adenosine is given in a controlled environment within MRI machine while doing the MRI scan, and following that a contrast is given. This helps us to differentiate between ischemic area and an infarcted area, where we can see clearly in this particular image, which is from a journal. This third column, what we're seeing is infarcted area, where there is myocardial thinning, perfusion defect, and late gadolinium enhancement. This is ischemic tissue where there is no much of myocardial thinning, but there is a definite stress perfusion defect in adenosine MRI, but there is no definite late gadolinium enhancement. So this is the way we can differentiate between hibernating or ischemic tissue and non-viable infarct in adenosine MRI. Then there is dobutamine stress MRI, where we look at regional wall motion abnormalities after giving low dose dobutamine in MRI. So in many centers, like Dr. Pankaj was saying, do not attempt doing adenosine and dobutamine MRI. The main reason is being there can be some minor side effects like bronchospasm, vasodilatation related side effects. But in an experienced hands and with a controlled environment with a good backup in a tertiary care, it's definitely possible to do adenosine MRI, and it is quite a safe imaging with a complication rate of less than 1%. So to generally talk about the advantages of MRI, we know that there is no radiation exposure, which is very important. And the greatest advantage of MRI is having a high spatial resolution. It gives a good functional analysis of the heart and the valves, and also importantly detects unsuspecting and coexisting pathologies of the heart. Coming to the recent advances in cardiac MRI, there is a lot of work happening in cardiac MRI in terms of parametric imaging. This is very important, and this is probably the future of cardiac MRI, where a T1 weighted T1 mapping, T2 mapping, T2 star mapping, and extracellular volume mapping. These are all the type of parametric imaging which is happening in cardiac MRI. The advantage of this is that you can detect disease process earlier than when late gadolinium enhancement happens in a particular patient, number one. Number two, it can also be done in patients with renal failure where you cannot give gadolinium. Therefore, you can just do a plain non-contrast study, and with all this parametric imaging, you can reasonably accurately say whether the myocardium is diseased or not. So this is called as parametric myocardial imaging, and it is upcoming and probably plays a very important role in patient management in the future. And myocardial strain imaging in cardiovascular MRI is also another important recent update, where most of the time this has been done in echocardiogram, the strain imaging, but now MRI is also being increasingly used And initially it was used for evaluating dilated cardiomyopathy and conduction abnormalities, but it is also a very important role in evaluation of ischemic cardiomyopathy and ischemic pathologies and coronary artery diseases viability imaging. Therefore, in the near future, you can expect more and more studies and more usage of this particular myocardial strain in cardiovascular MRI. So this is the brief overview I wanted to give on cardiac MRI. What are the advantages? What are the cases? What we have seen in our own center in Vijay Diagnostics, and what are the recent advances? So I would like to. These are my references for today's talk, and I would like to conclude here. I thank you all for your patient listening. Thank you.
Thank you, Deepak, for yes, Pankaj, go ahead, please.
Yeah, actually, very nice images he had shown, sir, and definitely I look forward that you give me. Actually, cardiac MRI we sometimes use for exact calculation of the ejection fraction, because ejection fraction what we get in MRI, cardiac MRI is considered as a gold standard. So that is very important, because 2D echocardiography sometimes gives a varying report. So when I am not able to, like patients, those who have RBBB or LBBB, where echocardiography doesn't give proper assessment, like somebody who wants to go for CRTD like pacemaker, which is very costly pacemaker, around 13-15 lakhs. So if the patient ejection fraction is less than 35%, then only we are supposed to go for this pacemaker actually. So sometimes echocardiography shows the borderline ejection fraction. So that time also we advise the cardiac MRI for the calculation of ejection fraction. So apart from the other pathologies and all ventricular premature complexes, somebody has frequent ventricular premature complexes, our electrophysiologist, and we always want to know any cardiac pathology like ARVD and non-compaction of LV, and there are many diseases like I have showed very good images of viral myocarditis. This kind of images we are definitely very interested to look for.
Thank you, sir.
Right. So, Deepak, I could see that apart from the routine MR and the delayed contrast enhancement, you spoke about adenosine stress MR, dobutamine stress MR, and then you spoke about T1 mapping, parametric, and myocardial strain MR. These are the future developments. And one of the important thing is clear-cut differentiation between the subendocardial ischemia versus transmural infarct. I think that is a very important point, because of the beautiful spatial resolution. We are able to differentiate that, thereby sort of assessing that yes, this is a salvageable myocardium. So that's brought out very nicely. And I think now we'll go ahead with role of nuclear medicine in myocardial viability. I would request Mansoor to go ahead with his presentation, please.
Good evening, everyone. Voice echo. Okay. Now that we've completed cardiac MR, we'll move on to nuclear medicine and role in myocardial viability. So in nuclear cardiology, in this talk, I'm going to cover myocardial perfusion SPECT. Myocardial perfusion SPECT uses radioactive isotopes that image myocardial perfusion. The prototype isotope we had was 201 thallium. This is a potassium analog, and it has good physiological characteristics, but the imaging part is not that good with thallium. And now, due to less availability of thallium, we're not doing thallium much. And the common tracers that we use day in and day out are technetium labeled sestamib and technetium labeled tetraphosphine. These are cationic compounds. Sestamib is a isonitrile compound and tetraphosphine is a diphosphine compound. They passively are transported across the cell membrane, and then because of the negative membrane potential in the mitochondria, they are fixed and they do not undergo redistribution like thallium. And imaging wise, they are much preferred compared to thallium. Then I will not go into the technicalities of imaging, and We'll just go and see some examples as we go through the talk, and after that we'll cover cardiac PET. That includes FDG PET as well as perfusion tracers, and we will briefly touch upon estimation of myocardial blood flow and myocardial flow reserve, and then we will finish with hybrid imaging, giving a few examples of hybrid imaging. The first case is 49 years male, diabetic with severe coronary artery disease and severe LV dysfunction with recent anterior wall MI. Coronary angio showed 90% stenosis in proximal LAD with spontaneous dissection, and distal 70% stenosis, long segment stenosis. Diagonals, LCX, OMs, RCA, and PDA were normal. We did a rest myocardial perfusion scan, and we can see that there is a severe perfusion defect involving the anterior septum, apex, apical segments, and anterior wall. So this is the short axis, the vertical long axis, and horizontal long axis. We are seeing a fixed defect there involving the septum and the anterior wall, and here also along the anterior wall apex we are seeing a severe perfusion defect in the vertical long axis, and in the horizontal long axis we're not able to see the septum and the apex. And this is a polar map which gives us a 17 segment model, and you can see that based on the color coding there is a significant decrease in perfusion. There is almost absent perfusion here, and we can say that the area which is very dark is a full thickness infarct, and the area which is showing a little bit of blue and purple color could be a partial thickness infarct, and based on the segments we can calculate the area how much is affected. This is a gated study where you are seeing that there is very limited wall motion, that is hypokinetic myocardium, dilated LV cavity, and no perfusion, no significant wall thickening, and no wall motion. So it's a full thickness infarct, non-viable myocardium with global hypokinesia and severe LV dysfunction. So this patient would probably not benefit from a revascularization based on this imaging. Case 2, another case of coronary artery disease with severe LV dysfunction. Coronary angio showed a plaque in the LMCA and a 90% stenosis in the mid LAD. Diagonals normal, 90% stenosis in the proximal ramus, non-dominant LCX with diffuse disease, and small vessel distal plaque in OM2 and small vessel OM1, and dominant RCA with significant stenosis. So this is basically a multi-vessel disease. And when we did the rest perfusion scan, we can see that there is a fair amount of perfusion and a dilated LV cavity. There are areas of hypoperfusion, but not completely absent perfusion. And based on the percentage score that we see here, we can calculate the amount of viable myocardium, and there are basically multiple partial thickness infarcts involving the anterior wall, apex apical segments, the lateral wall, and the inferior wall. So based on this scan, we calculated about 30% infarcts and 40% infarcts in the RCA and 40% infarcts in the LCX. There is significant viable myocardium, and this is the gated study. Here we are seeing the wall motion is significantly affected with a dilated LV cavity. This is a hibernating myocardium, but with a significant viable myocardium. So this patient would benefit from a revascularization procedure. We are seeing the RV myocardium also in this short axis here. So any acute ischemic event is described as stunning. After revascularization, there is a slow recovery of the cardiac function. Repetitive ischemic events and stunning can lead to hibernation, which is actually a protective mechanism where further ischemia to the heart is prevented by reduced cardiac function. So there is sometimes a need for pharmacological intervention, especially when there is moderate LV dysfunction in chronic coronary artery disease. So we do adenosine stress, and the whole idea behind doing an adenosine stress is to see how the coronary steal phenomenon is and what is the physiological significance of the stenosis in the diseased vessel. And sometimes I think almost in all cases, we give nitrates prior to viability study on the rest imaging, where the nitrates dilate the collateral blood flow and improves the perfusion in the diseased area, where we can pick up viability with increased sensitivity. So this is an example of adenosine stress, 69 years male with hypertension, diabetes, and chronic kidney disease, coronary and coronary artery disease post bypass surgery with an arterial graft to LAD and a venous graft to OM and PDA. With RBBB and moderate LV dysfunction. Adenosine stress scan was done. During the stress, patient developed ST depression in the inferior lateral leads. Here we are seeing in the stress images that there is hypoperfusion involving the inferior and inferior lateral wall, a dilated LV cavity, which is not as much dilated on the rest imaging. The bottom row is the rest imaging. And you can see on the polar map that the defects in the stress are getting partially reperfused in the rest imaging, especially in the LAD territory. So there is a partial thickness infarct with peri-infarct ischemia. It is involving the LAD territory, and there are infarcts involving the inferior lateral wall and the inferior wall with more severity in the inferior wall. So there is peri-infarct ischemia, and this patient will benefit with revascularization in the LAD territory. Now, moving on to cardiac PET. Why do we do cardiac PET in myocardial viability? Is that in an ischemic myocardium, there is a switch of metabolism from fatty acid to glucose, because it's more effective in generating ATP with the glucose metabolism. And so in spite of the perfusion defect that we see with the perfusion tracers, there we are seeing increased FDG uptake in the myocardium. So that further indicates that it's a viable myocardium in spite of absent perfusion there. So this is how cardiac PET is helpful if we see a perfusion metabolism mismatch. Here are two examples. This is a patient with disease in the LAD with a severe perfusion defect, and there is no FDG uptake at all. The bottom row is of FDG and the top row is perfusion. There is no perfusion here as well, and no FDG uptake. So it's a fixed perfusion metabolism matching defect. So it's suggestive of a non-viable myocardium in the LAD territory. Now, there is another example here where there is a perfusion defect again in the LAD territory with a dilated LV cavity, but we are seeing a significant amount of FDG uptake in the area which is hypoperfused. So this is a perfusion metabolism mismatch, which is suggestive of a viable myocardium. So non-contractive ischemic myocardium may recover function after revascularization, but the recovery of the function is not the main mechanism by which surgical revascularization improves prognosis. The main benefit of surgical revascularization is to prevent further damage by subsequent coronary events, and viability assessment can facilitate an assessment of the likelihood of successful revascularization of viable myocardial segments. But why PET? PET definitely scores over SPECT with higher spatial resolution, and the perfusion defect is much well visualized. This is an image of ammonia, and I had the privilege of working with an on-site cyclotron where we produced ammonia and did perfusion studies, and it has better attenuation correction by the help of CT that we use in PET-CT, and it has a higher accuracy and lower radiation exposure. And on top of that, there is a provision where you can calculate the absolute myocardial blood flow and myocardial flow reserve. What happens in a perfusion scan is, if there is a global ischemia, then identification of smaller perfusion defects becomes difficult. So that is where myocardial blood flow comes into picture. Smaller differences in extraction fraction can result in a clinical difference in the detection of myocardial ischemia by SPECT. Therefore, PET has the ability to quantify global and regional myocardial blood flow with units of ml per minute per gram of tissue. The different PET perfusion tracers that we use are O15, N13 ammonia, rubidium-82, and another fluoride labeled isotope, which is fluorpyridaz. The half-life is variable in all these, and they are basically short half-life isotopes, except for fluorpyridaz, which has 2 hours half-life. And they all need an on-site cyclotron, most like ammonia and water especially, and rubidium comes in a generator. And the stress imaging is possible with ammonia or O15 water and fluoropyridaz. This is the extraction of the perfusion. This dotted line represents the ideal perfusion tracer, which should be a slant line at 45 degrees angle, and O15 is very close to the ideal tracer, followed by fluoropyridaz and ammonia, which are very good. And then you can see that there is decrease in extraction with other tracers like technetium labeled and then thallium, and the technetium labeled system and tetraphosphine that we have, they have the least extraction. So they are not ideal for a quantification of myocardial blood flow. We can use a one compartment model or a two compartment model, and this is the acquisition parameter. First, we do a scout scan followed by a list mode acquisition that starts, and during the acquisition, we inject the tracer and do a first pass acquisition of the tracer, followed by stress, and then again acquisition starts, followed by stress injection. And then you can see the stress and rest perfusion images and calculate the myocardial blood flow. The different softwares available, which specially come into use when we calculate the myocardial blood flow. And these are the images, and these are the normal values. At rest, the value at rest is 0.7, and at stress, the myocardial blood flow increases to 2.9. And myocardial flow reserve is calculated by dividing the myocardial blood flow at stress by myocardial blood flow at rest. So when you look at the ideal tracer, it should have a high extraction with a good retention. So water is ideal as it has very high extraction, but at the same time, it has zero retention. It washes out of the cardiomyocyte very fast. Ammonia and fluoropyridaz, these are the two tracers that are also retained, so they are good with the imaging characteristics. And important points with estimation of myocardial blood flow and myocardial flow reserve is for the diagnosis, especially when it is complicated with diabetes, hypertension, and smoking and other risk factors. They can decrease the myocardial blood flow and myocardial flow reserve. And patients with preserved stress, blood flow and flow reserve are unlikely to have high-risk epicardial coronary artery disease, and severe reductions in global myocardial flow reserve less than 1.5 are associated with substantially increased risk of adverse outcomes and merit careful clinical consideration. A preserved global myocardial flow reserve of more than 2 has an excellent negative predictive value for high-risk coronary artery disease. So let us move on to hybrid imaging. This is the last topic for today's talk on nuclear cardiology. Here we have fused. This was a chapter in CSI update in 2019, which I had contributed as an author. So here we have fused a perfusion image with a CT coronary angio, and we can see that the lesions in the LAD and diagonals are corresponding to the perfusion defect in the apex apical segments and the anterior wall. And you can see the same image fused on a volume rendered image. We know that the prognostic significance of a CT coronary angio is not high, but when you do fusion of these images, you can see a hemodynamically significant coronary artery disease. And this is fusion of PET and MRI. And here we have a transmural infarct with late gadolinium enhancement showing no significant FDG uptake, and that is suggestive of a transmural scar. The benefits of fusing PET and MRI, we have a higher resolution image with simultaneous acquisition that offers better alignment of the images with no need for a special motion correction, and it gives less radiation to the patient. So that was for today. So summarize, we have the physiological significance of coronary stenosis can be assessed with the myocardial perfusion imaging. And the main role is to identify a non-functioning but a viable myocardium, and imaging at molecular level with FDG and other perfusion tracers that help in quantification of myocardial blood flow and myocardial flow reserve is an added advantage. And then this perfusion imaging helps in guiding management and predicting the improvement in cardiac function post revascularization, therefore guiding, also helping in assessment of prognosis of these patients. Thank you.
That was a beautiful and very informative talk, Dr. Mansoor. Thank you very much. So Mansoor told us a few important things. One thing is thallium is not in use anymore. Most of the time we still get the request for thallium stress test, and but we use cysteamine and tetraphosphomine. And then he also spoke about PET and the importance of perfusion metabolic mismatch. And he also talked about ammonia studies and myocardial blood flow studies. And finally, he also touched upon hybrid imaging with nuclear cardiology with coronary angio by CT and even nuclear medicine with MR. And nicely he has summarized. So thank you very much, Dr. Mansoor. So now, Dr. Pankaj, your comments and summarize.
Yeah. So one question I have, Dr. Mansoor, what is the sensitivity and specificity of stress myocardial imaging? Means that one case which I discussed with you, like patient is having 90% stenosis, but still in nuclear imaging we could find that there is no any inducible ischemia. Is that any false negative you think, or it is still it is possibility? Because there was one patient I remember. Patient is having CTO of one large OM, octis marginal artery, and patient was hesitant of not opening that vessel because he had suffered myocardial infarction, and another vessel was having CTO, that was large OM actually. So I went for again a nuclear stress test, and they showed that there is no even indicible ischemia in the OM territory. I was surprised that completely occluded vessel it is not showing. Maybe it is well collateralized. So, what is your take on this? Does it possible that we leave this patient on medical therapy despite the critical blockages in the coronary arteries?
Yes, sir. Sensitivity and specificity of myocardial perfusion imaging in assessment of ischemia is quite high, about 85 to 90% in various studies that has been shown. And, the reason why we get false negative for ischemia if the stress study is not performed well, and as you said, formation of collaterals. And if there is a full thickness infarct or a partial thickness infarct with no significant peri-infarct ischemia, that is one possibility. So sometimes, there can be difficulty in picking up peri-infarct ischemia. So proper visualization of polar map especially helps rather than visualization of the short axis and long axis views. So, and when you calculate the some stress scores and some rest scores, they also, give an indication of mild ischemia if it is present. And stress-induced LV dysfunction is also an important indicator. You see the ejection fraction in rest images and stress images and compare if there is a significant difference. That is also an indicator of ischemia.
Do you do any other studies like you showed PET? So do you have any stress PET imaging or something like that to know?
Yes, FDG stress was done in many centers, and it started in US, where Dr. Divakar, he used to do these studies a lot, and then Dr. Vikram Lele in Bombay started doing in India. So patient is made to exercise on a treadmill and given FDG, and the same concept that ischemic myocardium takes up FDG, that was shown, and that's how ischemia was picked up. But not a very common test. We used to do stress with ammonia, adenosine stress, and that was very helpful for us. And during my residency days in Apollo, I remember that ammonia was produced in the cyclotron, and we used to start simultaneously the stress on patient on the scanning table. And during the stress, we used to inject ammonia and do stress rest imaging. And you need softwares for that. And softwares are not available easily. You need to buy them, and not all centers have those. And PET is definitely helpful, and especially if you have the softwares to calculate the myocardial blood flow and myocardial flow reserve, that is very helpful in viability estimation.
So that means when you do stress nuclear stress also, And if you have these facilities, the sensitivity and specificity will go up further.
Yes,
So you can
further.
combine both the things, SPECT and PET, you can combine both.
SPECT
And
and
I think,
COMPAT we can combine in many centers, sir.
okay,
Perfusion with SPECT and metabolic imaging with FDG PET is done in almost all centers in Hyderabad now.
okay. Yeah, that's good information. Thank you.
Yeah, yeah, yeah. So I think we had a very useful discussion on this very interesting and very important topic. So one last question to Dr. Pankaj is, Pankaj, do you think you may be sending a bit more of MRI now than nuclear medicine, or you will continue with the same
Exactly,
practice?
sir. I will be writing your name and Dr. Deepak's name. And if you can give a good image, and I think I will be sending a lot of cases in my OP. I get a lot of. I one of the doctor. I won't say that, but I prefer doing a viability study in each and every patient. And I would like to
Right,
see each and every patient who has arrhythmias. And luckily, one patient came to my clinic. She was having multiple VPCs, and I got cardiac MRI done. I found there is a partial or localized non-compaction of LV, which was not at all seen in the echocardiography. So I was so impressed with the report. I said, "Arey, this is the diagnosis this patient is having." So it is very difficult to explain also in patient, because in medical language I don't know what to say in Telugu, how to explain the non-compaction of LV. It's very difficult. But I said there is some disease is there, but okay, you take on. We took the opinion of electrophysiologist, and they said it requires a lot of mapping and all. Better you keep this patient on beta blockers and amiodarone. She is doing very well, and her
right,
burden of disease has come down. So some such surprise diagnosis we get in cardiac MRI when we do, and I think we should do each and every patient these days should be studied. We should not leave them alone, and such a beautiful pictures will definitely change the scenario and the management and prognosis of the patient. And definitely, I would like to send more and more patient. Already, we are doing a lot of nuclear imaging is done by your hospital only, your diagnostic center only. And I think I will look forward to seeing more cardiac MRI cases also. That is for sure.
Thank you.
right. As the time is passing, technology is improving, our experience is improving, our confidence is improving. I'm sure we should be helping each other better and finally giving best to our patients. So, with these words, I think I must thank Dr. Pankaj for sparing his valuable time. He's a very, very, very busy person. I know it. And I also thank my colleagues, Dr. Deepak and Mansoor, for such beautiful presentations. So, thanks everybody for attending this. And I think now we'll close the session. Thank you.
Thank you,
Thank
sir.
you. Thank you, sir. Thank you for inviting.
All right.